Hi, Dr. Westgeest.
Hi, Darryl.
Hi, thanks for being part of our conference. A big question people have is whether clinical trials apply to them. And, we'll talk about that today. But first, could you tell us what you do and where you do it?
Yeah, thank you for the opportunity to tell something about my research. I'm Hans Westgeest. I'm a medical oncologist, and I work in the Netherlands, in Europe. And my hospital is based in the south of the Netherlands in Breda. I've been doing my research for a PhD project since 2011. And in the last 10 years, I built a registry in the Netherlands for CRPC patients, and in 20 hospitals, academic, large teaching hospitals, and smaller general hospitals. And we got a nice sample of patients in the Netherlands, approximately 20% of all CRPC patients. And we enrolled them in the years 2010 to 2016, so 6 complete years of patients. And we did a lot of research on those real-world data. Who are these patients? How are they treated? And what do we see in real-world practice on outcomes, for example? I used to do a lot of prostate cancer, and since 2015 I work as a medical oncologist, and I specialize more broadly in uro-oncology and melanoma treatment.
So let's talk about what real-world actually means when people use that phrase.
Yeah, I think all of the treatments for prostate cancer come from clinical trials. And if you want to participate in a clinical trial, you have to be included based on inclusion criteria and exclusion criteria. However, in real world, real world means what I see in my outpatient clinic. So people who come in here, they're just a sample from the population with prostate cancer, and they may not be eligible for a clinical trial because of, for example, maybe their age or comorbidity or clinical features. So real-world patients tend to be different than trial patients, and that's something that is very important to keep in mind. It's important for doctors. We have to consider: is this patient in front of me? Does he look like a patient in a clinical trial, or do we see some important differences that may have an influence on the treatment and the outcomes? And if you read scientific papers, you also have to be aware of this difference, because a clinical trial may have beautiful outcomes, but then you have to see, okay, is it on a population that I tend to see? And for example, the real-world population in an academic center or a referral center will be very different than a small general hospital, for example.
So, wait, I hear thousands of patients tapping on my shoulder saying, wait a minute, are you telling me that a clinical trial was done on patients that have nothing to do with my life experience?
They will have prostate cancer, obviously. And there are usually some, they want to select a target population, and usually that applies to you, the specific trials for that situation. But there are differences, and that's what we wanted to see. Okay, what are the differences? So that's one of our papers was focused on that, to see. What we did is, in that cohort of approximately 3,500 patients, we looked at the patients who were never included in a trial, the large part of it, approximately 85%. And then we looked at the patients who somewhere in their clinical course enrolled in a clinical trial, which could have been an intervention trial, large intervention trials. For example, the CUR trial with enzalutamide was running in the Netherlands, was one of the trials that people could be in. But also in other trials, post-marketing trials or other investigator-initiated trials. And then we looked, at baseline. So when the diagnosis of CRPC was set, we had two groups: people who somewhere in the future would enroll a clinical trial, and we knew that afterwards, and people who never got into a trial. And then we looked at the baseline differences, and it was already different at baseline. There were remarkable differences in age. So the patients in trials were much younger than patients in real world and the standard of care patients. And the prognostic features were better for patients who eventually enrolled in a clinical trial. So there were differences. And then we looked at the outcomes. The most important one is survival, of course, overall survival. And that was also different. So patients that enrolled in clinical trials had a better survival, median survival, than patients who did not. And then we did some analysis, and we found out that the difference was, for an important part, already set at baseline. So the prognostic features accounted for a big part of the difference we saw.
So, I mean, this almost reeks of conspiracy and such. Are clinical trials designed to have healthier patients so that the outcomes of the trial look better and can be marketed and more profitable to the companies?
No. There's no conspiracy in that. I mean, if you want to do a clinical trial and you want to compare treatment A and B, for example, you really want to look at the difference between the two treatments, and you don't want to look at other factors. So that's why they randomize, and ideally they do it double blind. And you want to have two groups that are more or less the same. And then you also want to have patients who will not die, for example, of another cause. So if they have a second malignancy, that can be the case. It's not wise to put them in the trial because they may die of the other disease. And you also don't want them to die from your treatment. So you want patients who are fit for treatment. So these are important in setting the eligibility criteria. And that's how these trials are set up. And then the trials are rolled out in certain hospitals, so not in all hospitals. And it tend to be more in academic centers, for example, and referral centers. Different patients go there. So if you are living somewhere in the campaign, or if I say it correctly in English, and you have to, you are old and traveling to the hospital is difficult, you probably go to the nearest hospital, and you won't go to a referral center, which may be miles away. So that makes a shift in populations. So it's not conspiracy, but it's just how it is. But we have to keep that in mind when reading the scientific papers, of course.
Well, not all of us are reading scientific papers. You and I have this quirk of enjoying that kind of thing. But the idea of patients wondering now, okay, I understand that a clinical trial is set up to get a pristine, perfect human being, as close to perfect as we can, with the disease. In this case, in our cases, usually castration-resistant prostate cancer, and then try out a molecule or a drug therapy on them, so we see it's not confounded by diabetes, perhaps, or a second or third kind of cancer and such. We all get, our audience understands that, but then how do doctors understand how to make sure that that pristine patient will relate somehow to the patient sitting in front of them?
You can just look at the table 1 in the trials. That's the table where the baseline criteria are set out. So you see the median age, and you see the Gleason score, you see maybe something about comorbidities and the exact stage of the disease and some lab values. So you can see, okay, what is the typical patient in this trial? And then you can just look at the patient in front of you and in the medical file and see, okay, is it more or less the same, or is my patient different? Well, an important thing is clinical condition. And for a clinical trial, usually people have to be in a good clinical condition. So no complaints or only minor complaints, minor symptoms, and yeah, in CRPC, as you all know, you can already in the beginning of the disease, you can have a very poor condition because of pain or fatigue, and your clinical condition can be really bad. Yeah, that is a difference with the patients who enroll in the trial. It's also because in a trial you have to to see if you can enroll. It usually takes a screening period of a couple of weeks, and you have to survive that screening period, of course. So if you have to start immediately, usually people don't go into the trial.
Mm. So is it fair to say that in most, if not all, outcomes of clinical trials will look snazzier and more optimistic than real world experience with the same medications?
It's what we saw in our research, and I saw it a lot when I looked at scientific papers on this topic.
Okay.
And it's because of the prognostic factors that we discussed already. It's also because people in trials usually have more treatment. It's an extra treatment, and usually if you are in an academic center, you probably have access to more other treatments as well. So, and there are also some other phenomena, such as that the doctors in a trial, they stick to the protocol. They look much more closely. There are more radiology assessments, and they see progression earlier, so they can act earlier. So all these factors play a role. And yes, I usually see that the trial populations do better than in standard of care. But it's not because the trials are added. The trial treatment is always better. And they can also, for example, be randomized to the comparator arm and still do better.
So it sounds like there are two messages for patients to take away. One, if you get involved in a clinical trial and you're lucky enough to actually be accepted and you have the capacity to get to the trial and back, you're actually in a good position. It tells you that you may be in better shape than you imagined, and that the odds are you'll have a more profitable kind of outcome, and your doctors around you will have better understanding for the rest of the world. But the second takeaway is that patients who sort of get stuck on the idea that real world outcomes are going to be less, how should I put it without sounding conspiratorial? They're not as good as what is advertised. That doesn't mean at all that the drug's bad. It actually means like we've actually have a deeper understanding of what
Yep.
the drug is about.
Yeah.
Because we did it under precise, let's say, laboratory or clinical conditions. So the doctor that's in front of you has a really clear understanding on how that drug or therapy will work for you. Is that fair to say?
Maybe to add something on that, I totally agree with what you said. We also looked in more detail at patients who got cabazitaxel as a second-line treatment. So very specific group. And why did we do that? Because in the period that we studied the patients, in the Netherlands were actually a couple of cabazitaxel trials running. And these trials had the same eligibility criteria as the TROPIC trial, which is the first registration trial of cabazitaxel. And then we looked at these patients that enrolled in a trial and got cabazitaxel, and patients who did not enroll in the trial and got the same treatment, cabazitaxel, just as standard of care. And then we looked at the differences in the populations between the two groups, so to say, and we looked at the outcomes. And what we saw that the group that enrolled in the trials, they had the same outcomes as the patients in the TROPIC trial years before. So a median survival of approximately 13 or 15 months from the treatment, and then we looked at the standard of care patients, and they did worse. They had a median survival of 9 months approximately. And we again looked at the reason, and they received a little bit less cycles of cabazitaxel, which may be part of the reason. But the most important one again was the prognostic features at baseline. And what can we learn of that? The first important lesson is that there is a group that is the same as in the trial. That's reassuring, I think. So there's nothing conspiracy about that. There's that group from the trial is there always. For the doctors as well, these patients are there, and they are mixed up in your population of patients. The second lesson is that if you are not eligible for the trial, you can look that up. Probably you have a worse survival. And if your doctor tells you your projected survival from the trial is 15 months, but you are not fulfilling the criteria for that trial, probably you do worse. And for second-line cabazitaxel treatment, we now know it's more in the range of 9 months. And that's important to know, I think, especially if you can make a choice, if you have an alternative, for example. I think patients need to be informed as good as we can, and that projected survival is then a bit less. That's unfortunate, of course, but it's good to know if you have to make the choice between treatments, or maybe if you want to not to have a treatment and only best supportive care.
All right. Well, thank you very much for your research on all this. It took years and much effort, and it provides our patient population with good questions for discussion with their doctors. And in a way, as you said, the outcomes may be slightly less, but the system works very well towards figuring out what kind of medications and drugs and therapies and such we should be doing.
So I think the doctor can tell you if the drug works, and then you have to know, okay, how good will it work for me? And that you can ask that to your doctor.
How good will it work for me?
Yeah. Or are there some differences? Yeah.
Excellent. All right. Thank you for coming to our conference and sharing that with us.
You're welcome.